Good morning, farm buddies. At least it's morning when I'm recording this lecture. So, chapter 41, we're talking about drug therapy for diabetes. This chapter is going to start out with the traditional review of the A&P. So, make sure you are familiar with diabetes. Make sure you're familiar with signs and symptoms of high and low blood sugars, as well as type 1 diabetes versus type 2 diabetes. The A&P is pretty important in this part to really understand how the medications are working. And when we go to the medications, really important that I'll put one more really more important that the peak onset and duration of your insulins. You're going to need to know this in the, sorry, that's my puppy, in the coming semesters. You're going to need to know this as a nurse. So just commit it to memory, peak onset and duration of insulins. When you're looking at your oral medications, a good way to organize those is thinking about what they're working on. Are they stimulating the pancreas? Are they changing how the liver is storing the insulin? Are they changing how fast the food is digested? That's a nice way to kind of organize it. It'll make more sense once we start talking about our medications. So let's start talking about normal function when we're talking about the regulation of blood glucose. So when I'm talking about blood glucose, I'm talking about sugar in the blood. So glucose is going to be our body's primary energy source. It is easy to break down, so the body likes to use glucose. Your brain almost exclusively uses glucose for energy. So you're going to start seeing when there's blood sugar issues, there's going to be some issues with mentation. So you might see confusion, you might see drowsiness. That's your brain saying, hey, I'm not getting what I need. We've got two major hormones that are going to be our big players when we talk about glucose levels. We've got glucagon and insulin. So both hormones are going to be secreted by the pancreas in an area of the pancreas called the islets of Langerhans. Sounds very fancy, doesn't it? So inside of the islets of Langerhans, we've got alpha and beta cells. So our alpha cells are going to secrete glucagon. Glucagon is going to work to increase blood glucose levels. We always learned it as if the gluc is gone, glucagon. So the glucagon is going to stimulate the liver to convert some stored glycogen to glucose for use by the body. So remember glycogenesis, that's when your liver kind of stores that extra sugar that we have. And it stores it as glycogen. So with glucagon, it goes down to the liver and says, hey, I'm going to need some of that sugar. So your liver is going to release that glycogen, it's going to turn it into glucose, and it's going to be used by the body. So the end result of glucagon is going to increase blood glucose. So that's why we say if the gluc is gone, we want to get the glucagon because that's going to help raise our blood sugars up. The other part of glucose management is going to be our beta cells. So the beta cells secrete insulin. Insulin is going to allow your body to use glucose. So it's kind of like a gatekeeper. It's actually kind of cool. So your body cells could actually be swimming in glucose, like literally surrounded all around, but they can't use it until insulin arrives. When insulin gets there, it kind of swings open the gate that lets the body have access to that glucose. And we know our body loves glucose. So if we don't have insulin around and we can't use that glucose, we don't have anything for energy. So no insulin's around, there's no entry. There's no entry to the glucose for the cells. But once we have the insulin, it opens up the gate. The cells can start using the glucose, right? And as we're using the glucose that's in the blood, it means there's not that much glucose left in our blood. So the level of glucose in the blood is going to be decreased because the body's using it. So the beta cells are actually going to lead to a decrease in blood glucose levels because the cells are able to use it. We're using it for our metabolism. We use it for everything we need. So alpha cells, glucagon, increasing the blood sugar. Then we've got our beta cells with insulin, and they're going to decrease the blood sugar. One more time for the people in the back. Glucagon. So glucagon is going to be secreted with low blood glucose. Remember, if the glucose gone, glucagon. So glucose gone, the sugar is low. We want to increase that blood sugar. So glucagon is going to help maintain glucose between meals. So let's say that you skipped your lunch because you were so enthralled with this Farm 1 lecture that you weren't even thinking about food. And then all of a sudden you have to go to work. So you bolt out the door to go to work. You get to work, your stomach's growling, you're getting a headache. Why are you getting a headache? Yes, because the brain loves glucose. So you start getting a headache and you're like, oh, I need to eat something. Well, you can't eat anything because you're really slammed at work. So this is where the glucagon kicks in. Glucagon kicks in because you haven't had any meals. Your blood sugar is starting to get low. It goes down to the pancreas and says, hey, blood sugar is looking low. We need to get some sugar out to this body. So glucagon comes out, goes down there and pokes the liver and tells the liver to release some of this stored sugar that's in the liver. So liver releases some of this sugar that it's stored, and your blood sugar is going to come up. Because you haven't had any sugar in your blood, because it's low, your insulin level is actually low and your glucagon's high because we were stabbing that liver, telling it to release that glucagon, right? So if you look on the other side of this little picture here, you can see after a meal. So, right, glucagon's between meals. After you eat a meal, we eat all that high sugary food and then some ice cream, maybe a milkshake afterwards, right? Our blood glucose is really high. There's a ton of sugar floating through our bloodstream. Remember, all that sugar can be around, but your body can't use it unless we have insulin secretion. So here comes the pancreas again to save the day, right? Pancreas releases some insulin. Your body is able to use up that sugar, and then your blood sugar is going to come down. So you can see after a meal, insulin's up, glucagon is down, but in between meals, you're going to see decrease in insulin and an increase in glucagon. I really love this chart. If you stare at it enough, I think it all will start to make sense. All right, so now we have a good grasp on glucagon. Let's go one more time back and talk about the importance of insulin. So again, insulin is going to come in after a meal. So remember how we skipped our lunch because we were so interested in farm, and that's when the glucagon had to come in. So now we've eaten a really big pasta meal, maybe had some cheesecake, maybe a glass of wine. So we've got gangs of sugar just floating through our blood, lots and lots of sugar in there. But remember, your cells can't use that sugar. They can just be, it can be all around them and they can't use it without insulin. So luckily, your pancreas recognizes this rising glucose level. It says, I see you, glucose. I'm going to jump into action. Insulin is going to come out. It's going to give the cells access to that glucose because your cells can start using it. Then it's going to decrease the level of blood sugar in the body. So insulin's going to do a couple of really interesting things besides give cells access to that glucose. The insulin is going to, like we said, allow the glucose to enter the cells. It's also going to let the cells store extra glucose, and they store that as glycogen. Remember, they tuck it down there in the liver in case glucagon needs it. They also can convert some extra lipids into fat, and they can increase protein synthesis to stop glucogenesis. So these proteins, the carbs, the glucose, they all get used up by the body. By making new proteins, they're stopping the breakdown of stored glucose in the liver. So insulin's doing all of these awesome things. So this is a pretty complex system, right? Not only does food or lack of food affect our blood sugar. We've also got some hormones that are going to affect our blood sugar, and we've, of course, got some medications that are going to affect our blood sugar. So a few more players in this glucose game. A few hormones that may have a smaller effect. So we know glucagon, we know insulin, those are the big guys, but then we've also got a couple little guys in here that can still affect it. So epinephrine, remember we've got that fight or flight. So our body's going to release some glucose so that we have more energy for the fight. We've got thyroid hormone. So thyroid hormone has a lot to do with metabolism. It can change how your carbohydrates are released. It can increase your blood glucose. We've got growth hormone. So growth hormone kind of counteracts insulin, and it decreases how much muscle is using up glucose. And then we've got glucocorticoids. So these are steroids. You can see gluc right in the name. So these sugary hormones, the steroids, they are going to promote glucose production in the liver. So we give glucocorticoids a lot. Remember, we've talked about giving steroids in the respiratory lecture for people that have asthma or COPD. One of the adverse side effects is they really increase blood sugar. You might see some drugs that can increase your blood glucose. Phenytoin, some beta blockers, NSAIDs, diuretics, they can raise your blood sugar. There's also some drugs that can decrease your blood sugar. Alcohol can decrease your blood sugar. Lithium can decrease your blood sugar. ACE inhibitors. Sometimes you'll actually see beta blockers on this list as well. Kind of depends on the person if they're diabetic or not at baseline. I'm not going to quiz you on beta blockers specifically because you can see, depending on the patient's baseline, if they're diabetic or not, you might see an increase or a decrease in blood sugar. But the take-home point of this slide is there's hormones and drugs that come into this picture as well and make it a little bit more confusing. So now we know what happens in normal blood sugar regulations. Let's talk about what happens when we've got dysregulation in this symptom. So diabetes mellitus, that's going to be our chronic metabolic disorder. So this is a chronic illness where there's deficient insulin secretion or there's decreased sensitivity to that insulin. We're going to talk about the difference between those two in the next couple slides. But our general definition of diabetes is going to be this chronic metabolic disorder, deficient insulin secretion, or decreased sensitivity to insulin. We have two different classification types, type 1 diabetes and type 2 diabetes. Both of them are going to be characterized by high blood sugars, but they're going to differ in how they start and kind of how they're treated and kind of what the cause of the high blood sugar is. So type 1 diabetes is going to be a more common chronic disorder of childhood. When I was younger, we used to call it early onset diabetes or like childhood diabetes, but now they found out that adults can get it as well. So it's just type 1 diabetes now, but it's more common in children and adolescents. It is caused by an autoimmune disorder. That autoimmune disorder turns the body's cells on itself, and so they start attacking and destroying your pancreatic cells, specifically your beta cells. So remember, beta cells are the ones that release the insulin. So your body starts destroying these beta cells, and then your body's not able to release that insulin. With type 1 diabetes, one of the keys is it's going to be a sudden onset. Like we said, usually a little bit younger, ages 4 to 20 is pretty common for the onset. Because it is kind of aggressive, it's a sudden onset, it is pretty difficult to control, and there are a lot of complications. Big thing with type 1 diabetes, put 3 stars by this one, because type 1 diabetes is attacking your beta cells, and your beta cells aren't making any insulin, and your body needs the insulin so it can use the blood glucose. We have to give insulin. Type 1 diabetes, insulin dependent diabetes. We're going to start talking about type 1 diabetes. So type 1 diabetes is a common chronic disorder of childhood. It actually starts as an autoimmune disorder. So, in autoimmune disorders, your body decides that it's going to attack its own cells. So, in type 1 diabetes, it starts attacking the pancreatic beta cells and it actually destroys all of those beta cells. So, we know our beta cells make our insulin, right? And insulin is how we use the blood glucose. So, if we destroy our beta cells, this body can't use that glucose and our blood sugars are going to get very high, right? So type 1 diabetes, we've got chronic high blood sugar because our pancreatic cells, our beta cells have been destroyed. Generally, we're going to see this as sudden onset, so it happens really quickly, and it's more common onset between ages 4 and 20, so usually in a little bit younger people, right? Because it's so sudden and kind of so aggressive by destroying all of those beta cells, there's a high level of complications and it's really difficult to control. Put 3 stars by this one. Make sure you remember this one. So type 1 diabetes. Remember, we've destroyed those beta cells, so there's no insulin. Remember, we need insulin so that our cells can use the energy. So because there's no insulin available, we need to give exogenous insulin. So exogenous means not made by the body. So we're going to have to give injections of insulin in type 1 diabetes. Type 1 diabetes is a little more rare. Only about 10% of diabetics are type 1 insulin. But again, it's difficult to control, a lot of complications. So you do see these patients. So type 2 diabetes then is going to be characterized by those same high blood sugars, but this time it's going to be caused by insulin resistance. So in type 2 diabetes, we have got the presence of beta cells. Our beta cells are working, insulin is present, but the insulin isn't able to work. So what that means is the cells can't get access to that glucose. So your liver, your muscles, the fat cells, they're not able to pull that glucose out of the blood. And that's going to leave us with that really high glucose level, right? The insulin receptors in the target cells, they're not responsive to the insulin. So all that insulin's floating around, but the receptors are just kind of like, meh, not worried about it. They think this is caused by the blood sugars being so high and so much insulin that's in there that they just don't get that excited anymore and they just aren't responsive. So this inability of the receptors to respond to the insulin is called insulin resistance. This insulin resistance is a big deal when you talk about type 2 diabetes. So again, type 2 diabetes, we're talking about the pancreas working, it's producing the insulin, but the cells just aren't recognizing the insulin. Generally, we're going to see type 2 diabetes after age 40, but we're really seeing a lot of increase in children and teens as well because we've got such an obesity epidemic. In type 2 diabetes, we're going to see kind of a more gradual onset, and your symptoms are less severe because we have some working insulin receptors, and some of them are going to be resistant. You get less severe symptoms. It's not kind of like, boom, all my beta cells are dead. You know, I've got some that are kind of working, some that aren't really working. This is the more common type of diabetes. About 90% of people that are diabetics are going to be type 2 diabetics. I do kind of like this picture talking about type 1 versus type 2 diabetes. So you can see on the left side, there's no insulin in there because there's no beta cells in type 1 diabetes. Then you can see over on the right side, we've got type 2 diabetes where there's insulin in there, but the cells just aren't very responsive to it. And that's going to cause that extra glucose to be in the system, both of them high blood glucose. All right, so like we said, type 1 diabetes is an autoimmune disorder, but type 2 is not. So we have a lot of risk factors that we can talk about when we're talking about type 2 diabetes. So risk factors for type 2 diabetes include obesity, a sedentary lifestyle, Presence of metabolic syndrome. So what's metabolic syndrome? Metabolic syndrome is abdominal obesity. So you see people that have a bigger midsection and like little legs. That's abdominal obesity. You'll see low HDL, which is a cholesterol level, high triglycerides, hypertension, high fasting glucoses. All of those are going to be part of that metabolic syndrome. So if you have metabolic syndrome, you're at a high risk for diabetes. Also, different ethnicities are going to be at a higher risk for development of type 2 diabetes. African Americans and Hispanics both have a higher risk of developing diabetes. So now we know how we get that high blood sugar. Let's talk about what kind of signs and symptoms you might have if you have hyperglycemia. So hyperglycemia is going to give you the 3 P's: polyuria, polyphagia, and polydipsia. Remember, polyuria is going to be frequent urination. I'm going to be running to the bathroom constantly. Polyphagia is I'm going to be extremely hungry. I'm going to be eating all the time. And polydipsia is thirst. So I'm going to be very, very thirsty. You're peeing all that time. You're going to be thirsty all the time. Those are usually the ones that you will hear the most common. I'm peeing all the time. I'm hungry all the time. I'm drinking all the time. And I'm just not, feeling like my thirst is quenched. You may also see glucoseuria. So glucoseuria happens when your blood glucose is so high that your kidneys start clearing out some of that extra glucose. So you're going to pee out some of that sugar in your urine, and your body's trying to correct that really high blood sugar. You might actually see some weight loss. And that happens because there is some metabolic changes that go along with diabetes that may cause that weight loss. You might also see fatigue as a symptom of hyperglycemia. Let's talk about some long-term or chronic complications from untreated diabetes. First one we're going to talk about is macrovascular complications. So macrovascular just means big vessels. So we're talking about hypertension, heart attack, stroke, peripheral vascular disease. Then we can also have microvascular complications. That's going to be the little vessels. So you might see nephropathy. This is damage to your kidneys. Remember, diabetes is going to be the top cause of kidney failure. We've got retinopathy. That's the little blood vessels in your eyes, so make you go blind. There's also neuropathy. So neuropathy is going to cause damage to the nerves in the peripheral nervous system. It can actually lead to complete loss of sensation in your extremities. I actually had a patient one time that had such bad neuropathy, he couldn't feel his feet at all. He told me that his feet were really cold. He was at a bonfire. He put his feet up to the bonfire to warm them up, and he actually ended up severely burning his feet because he had like zero feeling in there. And so his feet were so close to the fire that they got burned up, and he didn't even feel them from his neuropathy. Crazy. A couple other complications you might see that aren't listed on here. So an increased number and severity of infections. So these people are more likely to get sick. You're going to see poor wound healing because there's going to be a poor blood flow down there to those extremities. Diabetic foot ulcers are very common. So you've got decreased blood flow and you've got decreased wound healing. So high risk for those diabetic foot ulcers. And then also that poor sensation from the nerve damage, that peripheral neuropathy, that can be really dangerous. And all of those complications are, why diabetes leads to kidney failure, it leads to blindness, lower extremity amputations, really, really serious complications. There are also a few acute complications in diabetes that we need to talk about. So the first one we're going to talk about is diabetic ketoacidosis, or DKA. So in DKA, we've got a severe insulin deficiency. Usually this happens in type 1 diabetics. Maybe they're sick or they didn't take their insulin, so skipping that insulin dose causes this severe insulin deficiency because the cells aren't able to get any access to the energy, right? They can't use that glucose. They start breaking down fat. When the fat breaks down, it releases ketones. And ketones start building up and they lead to a drop in the pH. So that leads to metabolic acidosis. Body doesn't like metabolic acidosis. So our signs and symptoms then are going to be fruity breath. So we used to say it smells like juicy fruit, but I don't even know if they make juicy fruit anymore. So fruity breath smells like you just ate a whole bunch of melons. You're going to notice ketones in the urine, right? Those ketones come from breaking down the fat to get your body some energy. Your kidneys start to clear those, so you start to pee them out. So ketones in the urine. You also notice a change in your breathing pattern. There's a special kind of deep breathing pattern that's called Kussmaul's. So these Kussmaul's respirations happen when you're trying to blow off a little bit of that acid. So you're trying to increase your body's pH by doing this special type of breathing. You'll see severe hyperglycemia. So blood sugars are generally greater than 240. So because of that really high blood sugar, you're going to start to see that polyuria and polydipsia. You may see nausea and vomiting, and it can actually lead to a coma if your blood sugars get too high. To treat DKA, it's pretty easy. We are going to give a lot of IV fluid, so we're going to try to flush out some of that extra glucose and also try to flush out some of that acid that's making our blood so acidic. And then we're going to give insulin. So if it's caused by that insulin deficiency, if we give insulin, then your body's able to use those cells and it's going to reverse that DKA. Our next complication for diabetics is HHNC, or hyperosmolar hyperglycemic non-ketotic coma. That's a mouthful, right? So that HHNC, sometimes you'll see the C for coma swapped out with S for syndrome. It's still going to be the same thing, HHNC or HHNS. They said not everyone gets a coma. It's pretty rare, so it really should be a syndrome. There's lots of debate in the literature, whatever. The main thing is what's happening, right? So in this case, we have got life-threatening severe hyperglycemia, and this one usually happens in type 2 diabetics. So one of the big things is DKA is usually type 1 diabetics. HHNC is usually type 2 diabetics. So HHNC, like we said, more common in type 2 diabetics, also life-threatening severe hyperglycemia. In HHNC, that polyuria, so they're urinating so much that it leads to dehydration and electrolyte issues. The dehydration can actually be so severe that it leads to shock and to coma. Usually this occurs in people that don't even know that they're diabetic. So their blood sugars just get so high and they're just peeing and peeing and peeing and their electrolytes get all jacked up. And that's what kind of brings them into the hospital is, they don't even know that they're diabetic. So our signs and symptoms, you're going to see an extremely high glucose, usually greater than 600. So again, these type 2 diabetics, they don't know that they're diabetic. So their body's just not responding to the insulin any longer. They've got that insulin resistance, really high blood sugars. Those high blood sugars are going to lead to polyuria. All that urinating is going to lead to dehydration because your brain isn't getting the sugar that it needs. You're going to get drowsiness. You're going to get confusion. You're going to get coma. To treat this HHNC, we're going to have to give lots of fluid because they're severely dehydrated, right? So lots of IV fluid. Then we're going to work on bringing down that blood sugar. So we're going to give them insulin to help bring down that blood sugar. And you might need to treat some electrolyte imbalances. All right, last thing we're going to talk about before we start talking about our drugs. Let's talk about some lab values. Generally, we are checking our blood sugars if someone is eating and drinking before meals and at bedtime. That's going to be AC and HS if they're eating. If they're not eating, say they're NPO for surgery or they're taking tube feedings, or they have total parenteral nutrition through their IV. We're going to check their blood sugar every 6 hours because there's no meals to be had, so we'll spread them evenly throughout the day. We are going to consider an abnormal fasting blood sugar is greater than 126. So if you're looking at morning blood work and you see a glucose of 150, that should be a red flag for you. The goal for the blood sugar the rest of the day should be somewhere between 70 and 130. You're going to see a lot of variations between hospital agencies. Even each patient's going to be a little bit different. So don't chisel this one in stone in your brain, but kind of keep a loose idea in your mind. Normal diabetic blood sugars, we should be looking about 70 to 130. Last thing we're going to talk about, probably one of the coolest lab values we can check with diabetics, is called a hemoglobin A1C. So this hemoglobin A1C is going to measure your average blood glucose over a 3-month period. Normally, we want a A1C that is less than 7%. Over 7% is going to indicate diabetes. So this is a great lab value to kind of help diagnose, as well as look at the control of your blood sugars over 3 months. So say, 3 months you've done really well, but maybe Thanksgiving was in there. And so you ate some pie and you ate really bad on one day. But this is looking at over 3 months. So that one day is not really going to mess up that 3-month average. So I can look at, how have you been doing over the past 3 months? I can see, has your blood sugar been really, really high and I need to change your medication? Or has it been pretty good over the past 3 months that we're doing the right thing? Hemoglobin A1C, excellent for looking at long-term blood sugar control. Whew, we can take a deep breath. We made it through the A&P review. Time for a question. Is the following statement true or false? Diabetes is a chronic systemic disease characterized only by metabolic abnormalities. All right, I know that one was easy. I felt bad after that A&P review, right? So correct answer was false. Diabetes is chronic and it is systemic, and it does include metabolic changes, but it's also going to include vascular changes. So remember, we talked about hyperglycemia leading to those vascular complications. So the macrovascular, the big vessels, and the microvascular changes, the little vessels. So a lot of complications besides just metabolic. Question number 2, is the following statement true or false? Insulin is a hormone secreted by the beta cells in the pancreas. Boom. Correct answer, true. So yes, our insulin is secreted by beta cells in the pancreas. What do our alpha cells secrete? Yes, glucagon. That's what I'm talking about, guys. Excellent, excellent work. All right, this is a big deal. Make sure you know this slide. Hyper versus hypoglycemia. Let's talk about these signs and symptoms. This is going to be really important. I guarantee you're going to see this on the exam. If my patient has these symptoms, what medication would I expect to give? Something to lower the blood sugar, something to raise the blood sugar. So make sure you understand these. Our signs of hyperglycemia. Remember, we've got the 3 Ps: polyuria, polyphagia, polydipsia. So urinating a lot, eating a lot, drinking a lot. You might also see fatigue, weakness, and dry skin. We always say hot and dry, sugar's high. Next, we've got hypoglycemia. So hypoglycemia, we see sweating, we see tremors, you start to see tachycardia. Then you're going to see, the patient's feeling hungry. You're going to see those changes in the brain because it needs the glucose. Confusion, drowsiness can even lead to seizures. So hypoglycemia, we say cold and clammy, need some candy. All right, here we are talking about drug therapy. So the goal of drug therapy and diabetes is to control that glucose level, right? We want to keep it at a nice healthy range so we don't have all of those complications. We talked about the complications being pretty gnarly, so managing these blood sugars is going to help prevent all of those gnarly complications. So our treatments are going to depend on what type of diabetes you have. Type 1, remember, this is where your beta cells are destroyed. You're not making any insulin. So type 1, the only treatment you're going to see is giving insulin. Type 2 diabetes, look at this whole slew of medications we've got to talk about. We've got a whole gang of them, and you're going to see how they're going to work in different parts of your body. If you look over at this really nice picture, you're going to see them work at different parts of the body to help control that blood sugar. Some of them are going to work on the pancreas. Some of them are going to work in the GI tract. Some of them work in the muscles and fat and liver. All of the medications are going to help modify our blood sugars. So remember, type 1, insulin's the only thing. Type 2, we've got a lot of choices. Could be orals, could be insulins, could be a combination of the two. So let's talk about giving insulin first. So in the United States, when we are giving insulin, we give human insulin. It's actually a synthetic product. We're not actually sucking it out of humans, but it's a synthetic product identical to human insulin. When we're giving insulin, insulin is going to be given IV or sub-Q. There is no oral form of it. Most of the time we're giving it sub-Q, subcutaneously, because it has a special concentration, right? That U100 concentration. So 100 units of insulin per milliliter of insulin. We use a specific syringe when we're drawing up from a vial. Those orange capped syringes you see in the top picture there, or we use a specific insulin pen, which you see in the lower part there. Depending on where you work, it depends on which one you're going to see. Those are the only ways that we can give insulin safely. We can give regular insulin through the IV. We're going to talk about that in a little bit later, but regular insulin is the only one that can be given through the IV. There are multiple different types of insulin, and those insulins are going to vary in onset and duration of action. Again, it's going to be very important that you know the onset, the peak, and the duration of action with these insulins. All right, so here's the list of the insulins we're going to be talking about. We've got rapid acting, short acting, intermediate acting, long acting, and ultra long acting. So our fastest acting is going to be our Lispro or Aspart insulin. It's got a rapid onset and a little bit shorter duration of action. Next, we've got the short acting, which is regular insulin. Really important thing about regular insulin is the only type of insulin that can be given IV. Next, we've got our intermediate acting or NPH, and this has got a slower absorption and a longer duration of action. Next, we've got the long acting, the Glargine or the Detmar. So these long acting insulins provide insulin over a 24-hour period, and they act a little bit more like normal insulin release, kind of preventing those peaks and valleys of just kind of a more smooth release throughout the day. Last one we have is the ultra long acting or Degludec. So this ultra long acting is kind of nice because it provides insulin release over about 2 days, so the patient doesn't have to take as many injections, which makes them a little bit more compliant with the medication. While you're in practice, you might see several combinations. I know you guys learned about mixing insulins last semester, or maybe this semester. Depends on how you are in the program. But those combination of insulin, so you might see regular mixed with an intermediate insulin to give you that quick coverage from the regular to help cover for your meal, and then you get kind of a longer acting coverage from your intermediate action or your NPH insulin. So that's going to give you, that quick acting to cover you during that meal, and then a little bit slower acting to cover you in between meals. Really, really important. I think it's the third time I've already said this. You have to know the onset, the peak, and the duration. All right, here's the chart. Print it off, tape it on your forehead, put it on your bathroom mirror, whatever you need to do, commit this guy to memory. So this is where I am going to pull the questions about your onset, your peak, and your duration of the insulins from. This is the chart that you learned previously. This is the chart that you're going to learn in the future. So just keep memorizing it. So we've got the rapid acting, the Lispro and the Aspart. We've got onset 15 to 30 minutes. We've got peak 30 minutes to 2.5 hours, and our duration is 3 to 6 hours. We've got our short acting regular, onsets 30 to 60 minutes, peak 1 to 5 hours, duration 6 to 10 hours. We've got our intermediate acting, that's our NPH. So onset's 1 to 2 hours, peak is 4 to 12 hours, and duration is 16 hours. Then we've got our long acting, that's our Glargine or our Detmir. That's going to be an onset of 3 to 4 hours. There's no peak with this long acting because it's going to give you kind of like a smooth coverage without those peaks and valleys. And it's going to last for a 24-hour period, so you only have to take it once a day. To clarify, onset, so onset's when the insulin's going to hit the bloodstream and start to lower the glucose. The peak is going to be when the insulin is at its strongest blood sugar lowering level in the body. And the duration is how long you're going to have the benefits from the insulin. So if I was giving this insulin, when would I be checking the patient to see when they were going to have the lowest blood sugar? Would it be the onset, the peak, or the duration? So when would I expect the lowest blood sugar? Yes, during the peak. The peak is when it's working at its max blood sugar lowering capabilities. Onset is when it's going to start working. So you want to kind of time up the meal with the onset of the insulin. The peak is going to be when it's working its strongest, and the duration is how long it's going to be working in our body. So speaking generally about insulin, the action of the insulin is going to be increasing glucose uptake by the cells. Remember, it opens up the gates, that way the cells can use that insulin. It is also going to decrease the glucose production by the liver. Remember, when insulin's high, glucagon is decreased. So I'm going to use insulin to lower blood sugar. I can give regular insulin IV. Remember, regular insulin is the only one that I could give IV in an emergency. And insulin can be used in children and in older adults safely. Only contraindication that we have with insulin is hypoglycemia, which is pretty obvious. If our blood sugar is already low, I would not want to give insulin. It's just going to make the blood sugar lower. Probably the most important thing when we're talking about giving insulin is our timing with the meals. So you want to plan your onset to start with the meal. So if I am planning to give my Lispro before breakfast, I want to give my Lispro 15 to 30 minutes before I eat breakfast. That means it's going to start working right as I'm eating my meal. If I'm going to give my regular insulin with breakfast, same thing. I want to time up my onset of the insulin to when my meal starts. So regular insulin, I want to take it 30 to 60 minutes before I eat my meal. Again, we want that onset to start with the meal. If I would ask you a question about when the patient might need a snack because we're worried about low blood sugars. So that's going to be right at the peak. That's when I'm worried the most about low blood sugars. It's the peak of the insulin. It's when it's working the strongest. So our adverse effects with insulin would include hypoglycemia, obviously, right? That's kind of the desired response to lower the blood sugar, but we'd want to be careful of lowering it too much. Also, we can be concerned about some local site reactions, so kind of some pain and redness at the injection site. This is why we rotate injection sites. Remember, with insulin, sub-Q, you can use top of the legs, abdominal tissue anywhere an inch away from the belly button, or the back of the arm. Our drug-to-drug interactions, we want to be careful with any medications that can affect glucose levels. So we talked about beta blockers, we talked about aspirin, we've talked about NSAIDs, there's quite a few of them. So be careful with any drugs that affect blood glucose levels. our nursing implications. So as a nurse, we need to be aware of our onset and peak. That way we're aware of meal and snack times. We also want to make sure that we are rotating our injection site to prevent that irritation. Research has shown that the abdomen has the best absorption, so we recommend using the abdomen as the best injection site, but we do recommend rotating it. Also want to make sure you're monitoring your patient for signs and symptoms of hypoglycemia while the patient is sleeping. Obviously, they're asleep. You're not going to necessarily notice if they're extra drowsy. So you need to, keep an eye on them if you've given them insulin before bedtime. Briefly, insulin pumps. So insulin pumps are going to provide a basal dose of insulin. Usually with an insulin pump, you're going to see regular or rapid acting insulin, so it can, go along with your meals. Patient can set the pump to give them boluses with their meals, and that basal dose is kind of like a continuous underlying level. It just works a little bit more like your body. Depending on where you work, sometimes in the hospital, they'll make you remove the patient's insulin pump so that we can manage it, giving them insulin shots. Sometimes we'll let the patient manage it with their pumps because the pumps are really effective at keeping a nice tight control on those blood sugars. Last thing that's important as a nurse, insulin is considered a high-risk medication, so make sure you know your agency's policies. A lot of agencies are starting to have 2 RNs sign off on a medication. Because insulin is such a high risk, it's been switching over to being considered that high risk medication that needs 2 RNs to check off on it. We want to talk about programmed insulin versus sliding scale insulin. I'm going to talk about that in a little bit. And then we also want to make sure we know our agency's hypoglycemia protocol. So if I'm looking at my insulin orders, I may see 2 different types of insulin orders, programmed and sliding scale. So programmed insulin is a set amount of insulin that is given to cover for the meal. So this set amount of insulin is given generally with your meals. Again, it's a set quantity, kind of regardless of what your blood sugar is, you're going to get this set amount of insulin to cover for your meal. So the important thing to think about with programmed insulin is we want to make sure that our patient is eating. If our patient is to become NPO, maybe they're having surgery, so they're not eating and drinking, you wouldn't want to give this programmed insulin because there's no meal coming. That's when you want to call the doc and say, hey, the patient is not eating anything, they're NPO, and they have this programmed insulin. What do you want me to do? To give you a kind of example of what the order may look like, I put a little example down here, 5 units of Lispro sub-Q 3 times a day with meals. Hold for a blood sugar less than 70. So this is a totally appropriate order. Give this insulin with meal, so your patient's eating. That set quantity is to cover for the amount of food that they're eating with their meal. If their blood sugar is below 70, you wouldn't want to give this insulin because it could make their blood sugar too low. The next order we may see with insulin is called sliding scale insulin. Sliding scale insulin is given based on their current blood sugar level. So unlike the other one, it's not a set amount. The amount to be administered is going to be based on what their blood sugar is. So with the sliding scale sample I put down here, you'll look up what your patient's blood glucose is. So say, for example, your blood glucose is 253. So you would look down here at 253, and if you run your finger over, you will see we are to give 8 units of insulin. So the higher the blood sugar is, the more insulin that we're giving. Sliding scale is nice in addition to that programmed insulin. So sometimes you'll give programmed insulin to cover for the meal, and then you'll give sliding scale in addition to cover for where their blood sugar is at. Generally, if your patient has been made NPO, we would not give that programmed insulin, but we could still give our sliding scale insulin because the idea is it's covering for where their blood sugar is right at that time. So if their blood sugar is not high, then you could see The top one there, if their blood sugar is 61 to 150, we don't have to give them any insulin, so there's nothing to worry about. So generally, if patients are NPO, you will see them continue the sliding scale because it is based on blood sugars, not based on a set amount to go with meals. So insulin's a lot. New diabetics are really scared about giving themselves insulin. So patient teaching is going to be key here. One of the things we like to teach our patients that are new diabetics is teaching them about their diet, their weight control, and exercise. So weight control and exercise can help with that insulin resistance if they're type 2 diabetic. You control your weight, you exercise, there's less glucose, less insulin floating around through your bloodstream, and then your receptors are going to be a little more sensitive to them. Diet is going to be important when you are a new diabetic. Usually they recommend kind of a pretty standard diet. That way you can know how to give your insulin, make sure you eat breakfast, give lunch, give dinner, so that you can give your set or programmed insulin 3 times a day. You know how to manage it that way. You can make sure your patients know the signs and symptoms of hyper and hypoglycemia, and they know what to do. Remember, hot and dry, sugar's high, cold and clammy, need some candy. We got to teach our patients that so they know what to do. You also want to teach the family what to do if somebody has hypoglycemia, because they may be too out of it to know what to do. My stepdaughter, she's in marching band, and the little girl that marches beside her is a type 1 diabetic. So she's got all kinds of stuff in her bag in case her blood sugar gets low. She's got snacks in there. She has a glucagon pen, and they taught my stepdaughter how to give that stuff in case the little girl that marches beside her would start getting too confused or start to show signs of hypoglycemia, so that my stepdaughter can help her. So teaching the family what to do in case something happens. Make sure they go to their follow-up appointments. All those complications, you want to make sure they're seeing all their doctors to make sure there's no complications. Make sure they know how to test their blood glucose as ordered, know how to use their glucometer. You also want to make sure they understand the sick day plan. We're going to talk about that later on. And you also want to teach them the proper injection technique for a sub-Q. If you're a little rusty on a sub-Q injection technique, now's a great time to take a look. All right, on to question number 3. Is the following statement true or false? Insulin plays a major role primarily in the metabolism of carbohydrates. Correct answer is false. Insulin's going to affect the metabolism of everything: carbs, fats, proteins, and how the cells are able to gain access to those nutrients. All right, now we are moving on from insulins to the oral anti-diabetic medications. So when we talk about these oral anti-diabetic medications, keep in mind a couple things. Remember, if these medications are working on the beta cells, then they will only work on type 2 diabetics. Remember, the only thing that works on type 1 diabetics is insulin. Their pancreas does not have beta cells, so no matter how much we try to stimulate that beta cell, it's just not going to work. So these oral anti-diabetics are not going to help type 1 diabetics. These are all for type 2 diabetics. Another thing that's important to think about with the oral anti-diabetics is the textbook says you cannot use oral anti-diabetics in pregnancy. We generally want to switch our patients over to insulin so we can keep a really tight control on their blood glucose when they're pregnant, because it can wax and wane so quickly. Insulin gives us a better control than these kind of long-acting oral medications. I know in real life, some people may say, well, I was pregnant and I took oral anti-diabetics. Yes, that's in real life. We're talking about textbook life right now. And the textbook says no pregnant ladies are taking oral anti-diabetics. So that's what we're sticking with. Sometimes in real life, you see different things, but we're sticking with textbook reality for this lecture. So first oral anti-diabetic we're going to talk about is sulfonylurea. Our example drug is going to be glyburide. So glyburide works to stimulate the pancreas to release that insulin, and it helps to increase the number of insulin receptors. So remember, we said in type 2 diabetes, we've got some insulin resistance. Those insulin receptors just don't really pay attention to that insulin. So glyburide works in two ways. You're kind of stimulating that pancreas, and you're stimulating those receptors to help notice that the insulin's there. We're going to use this medication to treat elevated blood sugars. And again, your patient must have some functioning beta cells, so they should be a type 2 diabetic if we're going to give them the sulfonylurea glyburide. Our main adverse for sulfonylureas is going to be hypoglycemia. Our contraindications include sulfa allergies and renal and liver failure. Our drug-to-drug interactions are going to include other drugs that can lower your blood sugars, like beta blockers and alcohol. Bad idea to mix those together because they may kind of double up the strength of the drug and make you hypoglycemic. And then I have put all the patient teaching, because it's very similar for the oral antidiabetics, at the end of the PowerPoint to kind of make it a little easier for you guys to study. Our next oral antidiabetic is going to be acarbose. It's an alpha glucosidase inhibitor, right? These ones are mouthfuls. So the alpha glucosidase inhibitor, acarbose. So this one works a little bit differently. It works on your digestion. So it delays the digestion of carbohydrates. You can see carb right in the name to kind of trigger you to think about the digestion of carbs. So by delaying that digestion of carbs, it's going to decrease the blood sugar rise right after a meal. Generally, this drug is going to be given along with another medication that actually helps to decrease the blood sugar. This one really has to do with kind of changing the digestion after a meal. So our adverse effects with alpha glucosidase inhibitors like acarbose include hypoglycemia and GI upset. So GI upset may include gas, diarrhea, cramping. If you think about it, because it's affecting how the carbs are going to be digested, GI upset kind of makes sense. Our contraindications for these medications include liver disease and bowel problems like irritable bowel syndrome. Drug-to-drug interactions include mixing this drug with digoxin, because it can decrease digoxin levels. And we know digoxin is a really strong cardiac medication that we want to make sure that the level is in the right range. So it's a dangerous interaction there. As a nurse, one specific thing for this is we want to make sure we're giving this medication at the beginning of the meal. Again, it works in the GI tract to interfere with the digestion of carbohydrates, so it makes sense to take it at the beginning of a meal. Our next class are biguanides. So biguanides, our example drug is metformin. Metformin's probably the most common choice for oral antidiabetics for type 2 diabetics. We use metformin quite a bit. Metformin works to stop the liver from producing extra glucose when it's not needed. It increases the use of glucose by the muscles and the fat cells, so leads to an overall decrease in blood glucose level. So this medication is going to be good for insulin resistance. Like I said, commonly the first choice for type 2 diabetes. It has an off-label use to help treat polycystic ovarian syndrome. So sometimes you'll see it used for that if your patient's not a diabetic, but they are taking metformin. Adverse effects from our biguanides like metformin, you might see lactic acidosis and GI upset. But what do you notice that's not listed under our adverse effects? Hypoglycemia, right? Kind of interesting. So metformin, even if we give it in really large doses, is not going to cause hypoglycemia. We do have quite a bit of contraindications with these biguanides. So we have a black box warning to avoid using in older adults over 80 years old because there's a high risk for that lactic acidosis. Also, want to avoid using this in patients with renal failure. Put a star by this one. You want to hold metformin 48 hours before and after any contrast media. So any kind of test that has dye. If they're getting a CAT scan with dye, if they're getting a heart cath with dye, anything that has dye, kidneys hate dye. And so if I am giving metformin and that dye, you can cause renal failure. 3 stars by that. Hold metformin 48 hours before and after anything with dye. As far as nursing implications, you want to make sure you're taking metformin with meals. If you mix it with furosemide, digoxin, or vancomycin, it can increase the effects. And you want to monitor your renal function and monitor for lactic acidosis. Our next class, we have the TZDs. This is one of my favorite drugs because it has such a pretty name, rosiglitazone. So rosiglitazone is going to stimulate the insulin receptors on the muscle and the fat in the liver. And this is going to help the body use the insulin better. Generally, you're going to see this used in combination with insulin or sulfonylureas or bigonides. It helps to decrease insulin resistance. So it doesn't actually do anything with your blood sugar per se, but it's going to help decrease that insulin resistance so that your body can use the insulin properly. Our adverse effects with our TZDs, like rosiglitazone, we've got adverse effects, hepatotoxicity, congestive heart failure, and weight gain. You want to avoid using TZDs with liver disease and cardiovascular disease. There's actually a black box warning for a risk of heart failure and MI when it's taken with the TZDs. As far as a nurse, when we're giving this medication, we want to make sure that it's given with a meal. You want to monitor your liver function. You want to monitor your patient for signs of heart failure. A drug-to-drug interaction we have is gemfibrozil may increase the effects of the TZDs. And another really important thing to note is this medication may take 12 weeks to reach its peak effect. So tell your patient not to stop taking this medication if they don't notice any effects right away. It might take up to 12 weeks. Our next class is the meglitinides. Our example drug is repenglide. So this next oral anti-diabetic medication works by stimulating the pancreas to secrete insulin. So again, if we are stimulating the pancreas to secrete insulin, I need working beta cells. So we're only talking about type 2 diabetics with this medication. Generally, we are going to see it given in a combination with other drugs like a TZD or a bigonide, and this medication is going to be used for elevated blood sugar. Our adverse effects with drugs like repaglinide are going to include hypoglycemia and GI upset. Our contraindications, again, are going to be renal disease and liver disease, as well as type 1 diabetes. Why? Yes, because we need beta cells for this medication to work. Our nursing interventions when we're giving this medication include we want to give this med just before meals. If we skip a meal, we got to skip the dose. If we add a meal, we need to add a dose. We also have a couple of drug-to-drug interactions. We've got gemfibrozil and itraconazole are going to increase the effects of this medication. You're doing good, guys. We're almost there. Our next oral anti-diabetic medication we're going to talk about is a DPP-4 inhibitor, sitagliptin. So this drug's a little bit newer drug, and it's kind of cool because it kind of balances the release of insulin and the release of glucose from the liver by inhibiting glucagon secretion. And it's also going to work to delay some gastric emptying, so it'll make you feel fuller sooner and hopefully lead to a little bit of weight loss, which is going to help with that insulin resistance. Again, it's going to need working beta cells, and it may be given in a combination with some other medications. Some adverse effects of these DPP-4 inhibitors like sitagliptin include kind of oddly respiratory tract infections and heart failure. This medication would be contraindicated if you have type 1 diabetes, if you are using insulin, or if you have renal failure. And this drug can be taken with or without regards to the meal. So again, I find this goofy picture. It looks like I drew it, but I really didn't. The DPP-4 inhibitors work in a couple different ways to alter the increase in insulin and alter the decrease in glucagon that happens when you're eating a meal. So these ones work kind of nicely. So the next two drugs that we're talking about are going to be injections, but they are usually given in addition to oral antidiabetics. So we tucked them in here at the end. The first one we're going to talk about is an amylin analog, and our example is pramlintide. So pramlintide is going to work on suppressing glucagon. It is going to slow gastric emptying, and that's going to slow the release of glucagon, because remember, glucagon comes out in between meals. So if your stomach's slowing the release, it's kind of like you're not getting that glucagon stimulation that's going to raise your blood sugar. This medication is usually going to be given in addition to insulin, to a sulfonylurea, or to a biguanide. And again, it's going to minimize the spikes in glucose after meals, might help you lose a little bit of weight, feel fuller sooner. So again, hopefully you lose a little bit of weight, and that will help to make your insulin receptors more sensitive. Our adverse effects with amylin analogs like pramlintide include a risk of hypoglycemia. So the risk for hypoglycemia is actually so high that they have it as a black box warning, severe hypoglycemia, if you are giving the amylin analogs with insulin. As a nurse, when we're preparing to give these amylin analogs, we obviously want to make sure that we're monitoring our blood sugars really closely, because that's severe risk for hypoglycemia. You want to avoid giving this medication with other anticholinergics, because it's really going to slow down that GI tract. This medication hopefully is going to slow down the gastric emptying. Like we said, might lead to some weight loss and hopefully better glucose control. And this medication is usually given as a sub-Q injection before meals. I put a little picture of the pen there so you guys would remember that this is a sub-Q injection. Our next kind of helper drug is an incretin mimetic. So these incretin mimetics like exenatide, it is going to stimulate the pancreas to secrete the right amount of insulin based on what you've eaten. Incretin is one of those GI tract, like gut hormones, that is sensitive to when you're eating. So this medication kind of stimulates your gut to be a little bit more sensitive to the food that's coming in. And it's going to be used as a combination, like I said, a helper drug with some of these other oral medications. And it can be used to decrease that rise in blood glucose after eating a meal. Adverse effects with our incretin mimetics include hypoglycemia, GI distress, and pancreatitis. The incretin mimetics like exenatide should not be given to patients that have liver disease, and they also include a black box warning for thyroid cancer. As far as nursing implications when you're giving this medication is also going to be an injection. It should be given within 1 hour of breakfast and dinner. It has to be kept in the refrigerator. There are some extended release versions available that only need to be given once a week, which is kind of nice. Patients like that. These are the ones that you kind of see on TV, Trulicity, that have all those fancy new commercials because these are new fancy drugs. And this drug hopefully will promote some weight loss, which can help make your diabetes better. All right, guys, last drug. It's probably our newest and most exciting anti-diabetic medication that's come out lately. This one's going to be an SGLT2 inhibitor. Our example drug is going to be canagliflozin. It's a mouthful, right? Canagliflozin. This medication is actually going to work in your kidneys to promote the excretion of glucose in the urine. So you're basically going to pee out the extra sugar. This one is usually used as a helper drug, so it's going to help as a combination with other anti-diabetic medications. You'll see this one on TV a lot because it's new and fancy. Invokana is going to be the brand name if you've seen that on TVs before. I think I've seen it on Hulu and a couple ads. The probably only study tip I have on these oral anti-diabetics is trying to like pick out little letters and make little connections. Like the one has carb in it, and this one you can see flow, canagliflozin. So the flow in there, think of urine flow. So it'll help you pee out the extra sugar. Maybe that'll help you study. Sorry guys, I'm grasping at straws for study tips on this one. All right, because this SGLT2 inhibitor is kind of a newer medication, it does have quite a few adverse effects. Dehydration and hypotension are going to be our big concerns. Again, it's going to work in those kidneys to make you pee out the extra sugar, so that dehydration and hypotension makes sense. Because of all of that urination, you might see some electrolyte imbalance. With that electrolyte imbalance, you might see some loss of phosphorus and calcium, so you can see some bone loss. And then there's actually a new study out that said that this drug was linked with an increased risk of foot and leg amputations. So pretty serious stuff before you sign up to take this medication, right? Contraindications for this medication, because it works in the kidneys, kidney failure is going to be a contraindication. Just like with our diuretics, right? If you can't pee, this medication is not going to help you pee out that extra sugar. As far as a nurse, when we are giving this medication, you want to give it with the first meal of the day. You want to be cautious if you're giving this medication with other meds that might decrease blood pressure. Worry about hypotension, right? And then you want to be careful for the risk of dehydration or syncope because of that extra urine. You can worry about them, getting lightheaded and passing out. So in general, when we're teaching our patient about managing their diabetes, we want to teach them a consistent diet and exercise is going to give them the best control. If they eat kind of a boring diet at home, it's much easier to manage than if they're going out to restaurants and eating, spaghetti one day, hamburgers one day, salad one day. If you're staying at home, having a consistent diet, exercising, it's going to give you the best glucose control. We want to encourage our patients to maintain a normal weight. That's going to help, again, minimize any changes in their insulin sensitivity. Unopened bottles of insulin, we're going to store those guys in the refrigerator. We want to make sure our patients know the signs and symptoms of hyper and hypoglycemia and what to do if they notice either one of those symptoms. And again, teach a family or friend how to treat those signs of hypoglycemia in case the patient's too out of it to know what to do. You want to teach your patient to try to maintain their blood sugars to prevent those complications, right? We want that nice consistent diet, that nice consistent exercise, nice consistent management of blood sugars. Make sure they're going to their follow-up appointments so that we'll catch any of those complications. Don't start any new medications or new herbal supplements without talking to the doctor first. And also make sure you're notifying the doctor if your blood sugar is greater than 250. All right, so last important thing we're going to talk about is educating our patient on what they do if their blood sugar is super high or if their blood sugar is super low. So what we want to teach our patients, if they have hyperglycemia, they need to call the doctor if their blood sugar is higher than 250. They want to call the doctor if they notice ketones in their urine. Generally, type 1 diabetics have those little dipsticks that they can measure for ketones in their urine at home. If they notice those ketones in their urine, they need to call the doctor. They have a fever greater than 101, call the doctor. Vomiting and diarrhea, enough that they are not feeling safe about taking their medications, call the doctor. And if you have missed multiple doses of a medication, call the doctor. You see a lot hyperglycemia, a lot of it is calling the doctor, right? So on the other hand, if we need to manage our hypoglycemia, so this is really important here. So hypoglycemia, we are looking to give a rapidly absorbed sugar. These rapidly absorbed sugar is still going to take 10 to 20 minutes to work. It's going to be like the longest 10 to 20 minutes of your life if you're sweating your patient's blood sugar. So what's really important is the patient mental status. Are they alert and oriented? They can have a blood sugar that's in the 40s and still be talking to you. So if the patient is alert, we can give them something like 4 ounces of juice or 4 ounces of soda. You could give them a tube of glucose gel. I put a little picture down there of the glucose gel. It's kind of like a thick gelatin stuff. You just squeeze it in their mouth and they swallow it. It's like a sugary kind of candy stuff. They can also do 2 to 3 glucose tabs, kind of like a sweet tart, just like a really condensed sugar. That's going to take, again, 10 to 20 minutes to start working. You only want to do these oral treatments if the patient is alert so that they can swallow safely. If they are not alert, they're unable to swallow, then we want to give another route of medication. So we can give 50% dextrose through their IV. The first picture on the left there, you'll see it's a big ampule. Sometimes we call it an amp, half an amp. You give half of that container of 50% dextrose, a lot of sugar in there. So we give that through the IV, or you can give glucagon IM or sub-Q. Remember, when the gluc is gone, we give the glucagon. It's going to raise the blood sugar. We can give that IM, we can give that sub-Q. One of the key things is not to over-treat the low blood sugar. So you give this 4 ounces of juice and you just want to be like, why don't you just keep pounding juice or just drink this 2 liter of soda so I know that your blood sugar is high. But if we over-treat, then we cause hyperglycemia, and then you have to give insulin, and it's a whole thing with the risks of the peaks and the valleys. So only give what it's ordered. Only give 4 ounces of juice or 1 tube of glucose or 2 to 3 glucose tabs. Don't go whole hog, or you're going to not be doing your patients any services. So really important, again, make sure when you're thinking about the hypoglycemia treatments, if I tell you that the patient is lethargic or not able to swallow, we're going to give them something that's not oral. If the patient's talking to you, they can eat or drink something. All right, so managing sick days. Our patients are sick. What are we going to do? So if they are sick, that sickness is going to cause a stress response, and that stress response is going to increase our blood sugar. So patients need to continue to take their anti-diabetic medications. Remember, if they're not taking any insulin, then the cells cannot get any energy and they're not going to be able to help fight that illness. So make sure they're taking their anti-diabetic medications. They can check their glucose at least 4 times a day so they can make sure it's safe to take those medications, but you need to still be trying to take those oral anti-diabetic medications. You can test for the ketones in your urine. Remember, you're high risk for diabetic ketoacidosis if you're a type 1 diabetic, so they test for those ketones in the urine. If you are so sick that you're unable to eat, they tell you to continue drinking liquids. So you can drink 15 grams of carbs every 1 to 2 hours, and that should be enough to keep your blood sugar safe that you can take your medications. So it's only like 8 ounces of Gatorade. So 8 ounces of Gatorade is going to give you 15 grams of carbs, and you're going to be good. They also try to tell you to drink 2 to 3 quarts of water to help prevent dehydration, because if that blood sugar gets high, remember, you're going to start peeing a lot, polyuria. So your patient gets sick, at a bare minimum, you want to make sure that they are able to at least drink 8 ounces of Gatorade so they can still take their anti-diabetic medications. If they are unable to do that, then they need to give the doc a call. All right, we made it, buddies. Question number 4. A patient with type 2 diabetes is scheduled for a heart catheterization in 1 week. The nurse instructs the patient to stop taking which medication 2 days before the procedure? A. Sitagliptin, B. Insulin, C. Glyburide, or D. Metformin. Our answer is D. Metformin. Remember, I told you to put a star by that? So our bigonides, like metformin, can cause kidney failure if we're giving them 48 hours before or after anything that causes contrast dye. How about this meme I found, right? Classic. All right, so I know that you're feeling a little bit overwhelmed. I want to take a second and talk about organizing your studying. So insulin's pretty easy. Again, make sure you know the peak, the onset, the duration. I put a little sample here. This is just one that I stole off Pinterest to kind of help give you an idea how to organize. If it helps you, then use it. If it's not your jam, don't use it. I'd rather just memorize it than do this whole thing, but some people might like this. So there you go. As far as the oral anti-diabetics, I put a chart here, and there is a link to another chart up there that you can try. Just a way kind of to organize, how those medications are working, what are the adverse effects, your drug-to-drug interactions. A lot of them are very, very similar, so it shouldn't be too difficult, but try to remember the ones that are working on the pancreas. Remember the ones that are working on digestion of carbs. The ones that are the helper drugs, those kind of things. I know a lot of them are very similar, so hang in there. I'm not really trying to trip you up. I promise. Good luck studying. Let me know if you guys have any questions. I'm here for you. I'm really happy to help.